they've probably handed me 15 other pieces of paper to sign as well. I don't have time to read that in the 5 minutes it's going to be before my name gets called.
Oh, no, I read every piece of paper they give me. I do. I read every single piece of paper. And
what I like doing is going back up to the front with the NPP and saying, "Can you explain this to me?"
You're listening to the Help Me with HIPAA podcast, where HIPAA and humor collide to make learning fun. Your delightful hosts are Donna Grindle and David Sims. Relax. HIPAA help is on the way.
Welcome to the Help Me with HIPAA podcast. My name is David Sims of HIPAA for MSPs and Security First IT, and joining me is Donna Grindle of CARD. Welcome to 2019, Donna.
Oh, yeah, this is our first one in 2019.
I know.
Oh, wow. It seems like just yesterday we were worried about Y2K.
That's funny. It was funny because I was one running around going, "You better get this crap fixed."
Hey,
I was real, y'all.
I was busy fixing crap like crazy, Oh,
I was too. And I mean, I literally had people paying me to come talk about it and how, everything's going to shut down when the clock hits 12 o'clock. I wouldn't go anywhere that night because I was like, I'm not going to be around when stuff starts falling out of the air.
Well, I didn't go anywhere because I assumed I would be working all day the next day. So I was afraid that, we made mistakes and because we were writing code then. So,
yeah.
But hey,
I was running around and, replacing chips on motherboards and flashing BIOSes and all kind of stuff.
There's a new podcast that is talking about what happened during that time frame. And it's really interesting because it's discussing the, they're calling it the Y2K bug. It wasn't a bug. It was a design decision, but everybody called it a bug. It was a decision made by software developers and everybody just put it off. And, we still do that today, except now we're doing it with security.
Well, yeah, we do it with a lot of stuff. It's like, I won't be around when that comes up, so I'm not worried about it.
Yeah, I'm not going to worry about it till then.
But yeah, that was, I think we had like 3 months of food, stacked in a room, everything. I mean, we were ready for the end.
Oh, no, I wasn't that ready.
Oh, I was, dude. It was like the zombie apocalypse. I was ready.
No, I had some cash in case I couldn't get to the bank. And I had gas in the car in case, the systems all got screwed up. But other than that, I was good to go.
Yeah. No, I wasn't, running around, screaming the sky is falling. But at the same time, I had seen the problem. Like I, tested it and it's like, oh, yeah, this is a real deal thing. Because when I tried to go to 2000, my machines are rolling back to 1970. This is not good because... even today, if your clock and your calendar on your computer aren't right, things don't work very well.
Mm-hmm. It's still that. And we still have issues with dates and times. When the time change happened just recently, there were a lot of discussions about the Epic computer system that they just had to stop doing charts in the middle of the night when the time changed because the hospital systems couldn't handle it. Mm-hmm. And, everybody's like, how can this be? But being a programmer, I understand where the confusion might be, but there's got to be a way to handle it. Anyhow, There's our rant for the day. And I'll put a link to the podcast. It's the people that did Missing Richard Simmons. And now they're doing this thing. And I heard like the trailer or the intro, and I can't wait to hear the whole thing because it was like, wow, I forgot about that. And I forgot about that. So, and those of you who were not participating in the panic because you were too young, you ought to hear it because it's something else.
Yeah. Yeah. You say something to, somebody probably under, 30. You say something about Y2K and they're like, what?
Yeah. They don't know what it was like. I remember that night though.
All right. So that brings us to the next segment of our podcast. Let's discuss where you're going to be here in the first part of 2019.
Yeah, well, right now we have Middle Georgia MGMA on January 23rd in Macon, Georgia. And the 2019 Society of OMS Administrators National Conference is in Savannah, April 7th through the 10th. And then the end of April, going to be in Hilton Head with the Georgia MGMA expoing. And, we've got a lot to figure out on our schedule because we got HIMSS to worry about. We got National HIPAA Summit to worry about. We got to go to stuff this year instead of being stuff. That's what I'm trying to work out. So
lots of stuff.
Yeah.
And in the middle of all that, HIPAA Boot Camp. So we have HIPAA Boot Camp, our first one of the year, coming up March 20 through 22, 3 days. And by the way, the early bird pricing ends February 20th.
Yep. And there's only one early bird pricing. Then it goes to full price. So jump in. Get in while the water's nice. It's not boiling. But if you want to come in May, you have until April 15th. But if you want to come in March, you have until February 20th. So a little more than a month from now. Get everything approved. Get it all locked in. And we look forward to seeing you.
Yep. If you can't make March, maybe you can make May.
And if you are an alumni, give us a call because we have some special offers for you guys. And we know who you are, so don't try to fake us out.
I was there, I promise.
Yeah. So March and May, we have sessions. Go to helpmewithhipaa.com/bootcamp or
thehippaabootcamp.com.
Okay, we're clearly not in sync today.
I was not looking when you passed the ball.
You're not picking up what I'm putting down.
Yeah, I know. I'm just stepping over what you put. So in case you've missed it, there's been several headlines about HIPAA changes in the last month. I'm sure you didn't miss it, Donna.
No.
But the question is, is it things that we should worry about? So today what we're going to discuss is if HIPAA changes are in fact coming in 2019.
Yeah.
But even better, we're just going to, just tell people what to do with the information. But the one thing we'll go ahead and tell you right out of the gate, HIPAA's not going away.
No. So, we've heard that for how long now?
It's been a while.
No.
Every time there's some type of election of any kind, it's like, they're going to get rid of HIPAA. No.
No, and we know there's going to be other laws that will impact everybody in 2019. But our next episode is going to be about our watch list or our predictions or whatever we want to call it. We're working on it. But anyway, this HIPAA changes coming thing. Yeah. How many headlines have you seen about it? And they all, you can tell they didn't really read it all.
Yeah. Yeah. Well, one that kind of jumped out at me was earlier in the month of December where HHS was talking about, hey, we need some input on some changes we want to make.
Yep. And that's what prompted this episode on December 12th. They did publish a press release. It says HHS seeks public input on improving care coordination and reducing the regulatory burdens of the HIPAA rules.
Yay, reduce burden. Woo, woo.
Yeah, we're all for that.
Yeah.
However, it is not what people think. People rant and rave about HIPAA, yet they don't really understand it. And, you and I get to watch the comments on the message boards and stuff, and it's like, you don't even understand what you're talking about.
You're not doing HIPAA, so why are you complaining about it?
Well, and, it's bloated paperwork. Yeah, we're trying to get rid of that, but you don't have a clue what should be happening and what is happening to protect people. So,
yeah,
we are trying to teach the world about HIPAA. So, here's what OCR said in their, what's called a request for information, RFI instead of an RFP, request for proposal. This is request for information. So in the Federal Register, the official quotes say that they are issuing this RFI to assist OCR in identifying provisions of HIPAA privacy and security regulations that may impede the transformation to value-based care or that limit or discourage coordinated care among individuals and all of the healthcare industry. So it brings it up and then it says, without meaningful without meaningfully contributing to the protection of privacy and security of individuals, PHI. So basically they're saying we're looking for things that don't really add to the protections. They don't help protect things. So if they are protecting things, we want to keep them. And if they are, we want to make it all better, not make it go away.
Right.
So it's getting into that bit about without meaningfully contributing to the protection of the privacy and security of individuals, PHI. That is clearly stating we're going to preserve the privacy and security of PHI, basically.
Yep.
So there you go. It's not going away.
So, yeah, that piece is not going away. And honestly, you're not going to get away from it anyway, because if you deal with any other types of regulatory things, or even PCI, which is not regulatory, it asks for a lot of these same things. It asks for the documentation. It asks for security awareness program. It asks for a lot of the same technical aspects that HIPAA does.
Yeah, the new PCI stuff is very much HIPAA-like.
It is, and it's not going to be the end of that. Most things that are coming are going to be very much down the same line as what HIPAA is requesting.
Yes. So you want to do what your buddy Roger said, those are always important. His quote in the press release.
Roger says, we are looking for candid feedback about how the existing HIPAA regulations are working in the real world and how we can improve them. We are committed to pursuing the changes needed to improve quality of care and eliminate undue burdens on covered entities while maintaining robust privacy and security protections for individuals' health information.
Boom. There it is. Roger himself said, we ain't getting rid of privacy and security. We just want to make it better.
Yeah. No, it is not. It is not going away. But there are some things that, I do think they could do better. And I think they're trying to do things that are better.
Yeah. And they're asking for like general comments, but again, they're saying we would like for these to be productive, not random BS. But then,
good luck with that.
I know, right? But then they ask for very specific areas of the privacy rule. And these are areas where we already know they're trying to do stuff. They're actively involved in doing stuff, and they want some input on being able to do those. And this is where encouraging information sharing for treatment and care coordination. Yes. Facilitating parental involvement in care. Addressing the opioid crisis and serious mental illness. Accounting for disclosures of PHI for TPO, the Treatment Payment Healthcare Operations, which was added under the High Tech Act, but has never been implemented because no one can quite figure out how to do it without making it quite onerous. Changing the current requirement for certain providers to make a good faith effort to obtain an acknowledgement or receipt of the notice of privacy practices.
Yeah. How about get rid of it?
Right. So the ones that are just paperwork and really that one is the one that's mostly just paperwork.
Mm-hmm.
But they are opening it up for public comment, which means you've got until I can't remember, sometime in February that you've got to make your comments. And this RFI, don't think that you just get to, ramble off and they're going to pay attention. If they want you, if you're going to make some actual suggestions, you need to go read the RFI. It has very specific questions to answer. It's not just looking for prognostications. How'd you like that word I put in there?
Goodness.
I know. That was like several syllables. That is a $1.50 word in my 50-cent sentence. So what was interesting is the 54 specific questions, and some of them have multiple parts. And I pulled an example of just one, which is question number 31. Should the department require covered entities to account for their business associates' disclosures for TPO, or should a covered entity be allowed to refer an individual to its business associates to obtain this information? What benefits and burdens would covered entities and individuals experience under either of these options? That's one of 54 questions. And question number 32, what was it? Had A, B, C, D, E, F, and G.
Yeah, I had a lot of subsections. It's like, goodness.
So, that's hugely important to realize. They want very specific information. So if you want to do these, and hey, I'll be happy to help, work that out for you as far as putting those things into writing. But a lot of these things are not things that necessarily, I can give you my opinion and those kind of things. I've been trying to decide if I'm going to reply to the information, but that basically it's ain't nobody got time for that. But there's a lot of people that do have the resources to spend time evaluating those and getting the information in. So it's that stuff that really matters. And when you get into that level of detail, like I just went through in that question, that's great that if people will supply it, I think it'll be helpful. Mm-hmm. And there is one other area. Now, granted, this is a request for information. Now, we know how long it takes to get anything done. Once they get the information in February, sometime around the end of the year, we'll learn what they learned from that information request. Right? Mm-hmm. It ain't going to be like in March. But that you just... the volume and the requirements and the legal stuff is just, you got to remember, these are all lawyers doing this stuff. So it ain't going to be, anything we learn quickly. But they have done a rulemaking proposal on another part of HIPAA, and I don't want people to get confused about it. It's the part that everybody forgets that's part of HIPAA, the transaction code set standards, which make us do ICD-10 and ANSI and have NPIs and all of those kind of things. And part of that was that we were supposed to adopt a standard unique health plan identifier and an other entity identifier. This is part of the original stuff. And they say that, we're going to rescind that because the crap ain't going to work. Which is the proposed rule would rescind the adopted, these two requirements, basically, and implementation specifications for its use. The decision to propose to rescind the standards we made a careful assessment of industry input, as well as HHS's intention to explore options for a more effective standard unique health plan identifier in the future. Eventually, I think we'll see something like that for the TPO thing. They'll have to say, look, we're going to have a different kind of rule. Mm-hmm. But I don't think anybody will fight that, and it'll just go through. So that is going to likely change, but there's no actual rule changes proposed other than that. Along the lines of the other stuff is simply asking for information. So we'll learn later in the year if that turns into any rules. So, David, what do we think? If we could change things, what would we change? Yuck, 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 yuck.
Yeah, that would be interesting. Well, the first thing I think, I mentioned it a few minutes ago is, I think we should probably get rid of the requirement for a signature to be obtained on the NPP.
Yeah, people don't read it anyway.
No, they don't read it, but it should be posted in, all over the place. It'd be in the waiting room, the lobby area, on the website.
Yeah, people think I'm crazy when I ask for it. You're asking for me to sign that I've seen this. I haven't seen it. Where is it? Does anybody know where one is? Right.
I understand the purpose of having somebody sign it, but more than that, it should just be visible anywhere and everywhere easily. And whether somebody has to sign, they read it or not, it doesn't really matter because they're not going to read it anyway. Like you said, they're just going to get the piece of paper and they're going to sign it because, they've probably handed me 15 other pieces of paper to sign as well. I don't have time to read that in the 5 minutes it's going to be before my name gets called.
Oh no, I read every piece of paper they give me. You know I do. I read every single piece of paper. And
what I like doing is going back up to the front with the NPP and saying, "Can you explain this to me?" They're like, "I have no idea what it says."
I love it when you go get, and the one that's posted is from like 2007. You know that's wrong. But
yeah.
Anyhow, that's how we sell things, is we just say, look, I found like 5 things wrong when I was here.
Yeah, in the lobby.
And I heard way too many things. So yes, the that's just another piece of paperwork driving everybody crazy.
Mm-hmm.
I think, let's get rid of that because nobody cares. Nobody cares. Now, there are some other areas in the privacy rule that I think really need to change, and, or at least to add exceptions, and you're not really adding it, you're adding clarification, particularly because of all the things we know about the opioid epidemic. And they call it an epidemic for a reason. But the ability to share information with caretakers, family members, people involved in the lives of adult drug addicts, it can save lives, because there are cases where the doctors have said, I know they're addicted. I know that they need help, and they won't let me talk to anybody. And if the family had known that, and they could have a Narcan pen,
right?
For those who are not familiar, you can get this. It's like an EpiPen, but it actually reverses the effect of an opioid overdose. And there have been more than one occasions where parents have saved their children, and more than one occasions where they didn't know they needed to have one.
Mm-hmm.
And I think, the healthcare industry, when they're doing their job, they worry about the care of patients. And
but the flip side of that too is, making sure that, if somebody has an opioid prescription or a problem, or whatever, and everybody's not running around telling everybody.
I know, right? Sometimes, people have them, and just because somebody has one doesn't mean you need to go tell everybody they're a drug addict. Yeah. People use these drugs without being addicted every day. I certainly have used them in the past when I had some very painful things going on, and never once was I addicted. In fact, as soon as I got better, I still had extra pills left. So good
Never
thing.
once was I addicted. Isn't that the kind of famous last words?
I know, right?
I can handle this.
I know. I just know for a fact it's something that you need to be aware of, and as soon as you don't need them, stop using them. Period.
Mm-hmm.
But on the flip side of that, when you're in agony, don't get behind. Stay in front of it. That matters.
Yeah.
But it is a problem for a lot of people, and it's a serious problem. But at the same time, it doesn't mean you open the floodgates and let everybody talk about it just because you have a. If I see you in the PDMP, it doesn't mean I should tell everybody about it.
Mm-hmm.
Especially the doctors who assume that they know everything because they see one thing.
Yeah. It puts everybody in a bad situation. Do you say something? Do you not say something? How do you say it? Who do you say it to?
Yeah. But most times, in most cases, they will have somebody who knows and could say something, but they're not allowed to.
Right.
Now, it doesn't always happen. A lot of times they'll have people come in and they won't even know who they could talk to. But if there is an emergency contact, then, that at least helps. But another area is mental illness. And a lot of that has to do with some of these mass shootings by people who they knew were a ticking time bomb. But we don't have any mechanism in our healthcare system to do something about it. They know it's not like they're making a specific threat. If they make a specific threat, they know what to do. But if they just know they're kind of, teetering on, I think the best example was the Colorado movie theater case. And that guy, a lot of people knew he was teetering, but there was no mechanism that let anybody do anything about it. Everybody just said, look, I can't deal with you. You're out. The school Senate, got rid of him. And so we need some mechanisms to count on the professional judgment of mental health professionals and allow them to take action, because they're still protecting people.
Right.
It's one of those things. So I definitely think it, but all of those come into place where it's the spirit of the law is what matters. The problem is so many people don't get what the spirit of the law is. And that's what the judges always say. We believe the spirit of the law, blah, blah, blah. But that is the bottom line is, remember, why is this in place? This is in place to protect the healthcare system from running amok. And, there are people that once their privacy's been violated, especially in these individual cases, who say, I'm afraid to talk to my doctor.
Yeah.
I can't go to see my doctor in my town because I'm worried about it. So I have to drive 30 miles away or 50 miles away to go see a doctor that doesn't know anybody I know and hope that no one there knows anybody I know.
Mm-hmm.
That's just wrong. Shouldn't have to work.
Yeah. Well, I'm sure it happens, especially in the smaller towns as well.
Well, I could, I grew up where, I could see everybody's in family's house and we knew everybody that lived around. It's like my dad getting a Ring doorbell for Christmas. And he goes, I said, there's this neighbor thing where you can post your videos and everybody can share and ask about it. And he goes, well, I know everybody. They'll just tell me, but you got the video, Dad. It was just like, whoa. But it's the same kind of thing, in those small towns. But even in larger areas, you have that problem. You've got teachers and principals and anything that happens around the school system. Boom.
Yeah.
So, yeah. So, and then, so those areas in the privacy rule, I really see, that needs to have in some way be adapted to allow better care. And that's what they were talking about having the family members be able to be involved. Sometimes they don't have a clue that their family member has this addiction problem and they don't know what they should do about it. In other cases, they know about it, but the patient won't allow them to talk to the doctor about it and the doctor can't talk to them. So, it's a really complicated area, but we've got to do something because this is a major problem and people are dying every day. But when we move on to that accounting of disclosures, have you ever sat and thought about that one, David?
That would be a no, because that is a big old pile of mess.
Well, yeah, because when you think about everybody that's involved in treatment payment operations, that question about business associates, I included that because that's something you should think about. When everybody's like, well, you just print it out of the EHR. It's more complicated than that. Mm-hmm. So unless we narrow it down to say we're going to generate just what the EHR can do, that might help. But on the flip side is then you've got to standardize what you want the EHR to say because you're looking at a massive amount of data in people that are very ill. This is a massive amount of data. It's one of those, seems like a good idea until you sit down to do it. And then you're like, wait, what? It's a good thing, but it's one of those where you got to weigh how helpful is it? How many people will actually need to see it? You got nothing.
No, it's just mind-boggling.
I know. So it is absolutely overwhelming. And in the RFI, they said OCR has not taken action to finalize the proposed accounting of disclosures rules since the comment period ended in 2011, which, this was 2009 is when it was supposed to start. And they go, and it now believes that the proposed access report requirement would create undue burden for covered entities without providing meaningful information to individuals. Yes.
Tried it for a long time. It just ain't working.
Yeah, I mean, everybody is like, we should figure out how to do these things, but at the same time, wait a minute, the work involved, and can you get a meaningful piece of information from the data that you're going to get out of it? I might be able to read it because of years of reading raw database, but that's probably what you would end up getting in a lot of these cases.
Mm-hmm.
So, they're saying clearly that we want to make sure it's meaningful before we have people invest in a lot of stuff. And, it's probably in high tech. They said, look, if we're going to have all this electronic stuff, we should be able to track it. But it was written by people who don't live in that world and understand what that really means. When the study said that in a hospital, every 8 seconds, they're in a different patient account.
Mm-hmm.
And I mean, that's normal work. Every 8 seconds. Boom. It takes about 8 seconds for them to do what they need to do. So, interestingly enough, they really didn't specifically ask about a lot of security changes. However, I know we've got some ideas.
You need to listen to us.
Look at him now.
Look at him.
But yeah, this falls under general comments more than their specific requests. But I think that there's some stuff that could be done. I don't know about you.
Oh, of course.
So
absolutely. Well, using the NIST framework, because we talk about that a lot, of how they intersect, or there's a crossover between the two to make it easier and to be able to standardize, because a lot of the stuff that people say, well, HIPAA says to do this, but it doesn't give us any guidance on how to do it.
Mm-hmm.
It's kind of like, this is kind of in our opinion, something that would be good to do, but we're not going to tell you how to do it.
Well, and it's written that way on purpose, which is why it's lasted since 2005 without any changes, and it still applies.
Yeah, it does. The thing about it is there are certain areas, I think, adding some specific guidance would lessen the confusion and be better for everybody.
I concur.
I'm glad you do.
Well, and a lot of things, if you've never worked, I mean, the NIST framework does give us the taxonomy is the terms that match so that it is better, easier to communicate. Good Lord, just the risk analysis, risk assessment discussion. And is it a gap analysis, which in most cases we find that it is actually a gap analysis that somebody's done. It's not, if you're just going through seeing if they're got policies and procedures, it's not. But we've talked about that. Reference the episode, is it a risk analysis or a gap analysis, where we talked about that a great deal. But to me, one of the biggest areas is who is a BA and what must BAs do.
And why are we still talking about this?
I know.
It's been that way since the omnibus rule.
I know. And it's that clarification that there's some guidance from 2002 that we're still having to go by, that if they change that and updated, it's just guidance. It's not the law. It's just guidance. And if they would change that and update it to make it clear, if they went and pulled everything on the security rule that they published in 2002 and just, somebody has to review and make sure it still applies.
Right.
That would be great.
Mm-hmm.
But most important is give us some more specific, and I know that Devin McGraw talked about, it was kind of like case studies is what she was trying to, I don't remember what she called it, but she was talking about trying to develop things where it would really like tell you a story about here's what we looked at, here's what we found, and give you those details that, this is what they had done, but this is what we really wanted to see, and here's what we had a problem with. Instead of that very generic that we always see. They didn't have a complete and thorough risk analysis, blah, blah, blah.
Yeah. Can you explain that?
So it's kind of like a into the breach kind of thing. But if we had more of that really told the story of the evaluations that they've done and what they found, and mix 2 or 3 of them together, so we don't know who everybody is, but be able to have something where I can tell, I got a copier company that says because we're removing the drive and the drive is encrypted, we're not a business associate. Wait, let me explain. You're no different than anybody else taking an encrypted drive. Unless you wipe that drive before you leave, the minute you walk out the door, you're definitely a business associate. I might be able to argue it before then, but the minute you walk out the door, you're definitely a business associate.
Right.
And all of the IT providers, how many times do you hear that?
Yeah, it's not as bad as it used to be. I mean, used to it was just you couldn't get anybody to understand. Look, I understand you're not looking at the data, but that doesn't count into the factor here. You're still, maintaining it. You're still moving it from place to place when you're backing it up. You're doing all kind of stuff.
You have control of the entire network.
Yeah. But there was some guidance that came out. I don't remember when it was, but it did specifically mention IT providers.
And that helped.
In passing. But yes, it did help because people would say, I looked at the list of what a BA's and we're not listed. I'm like, that's a sample list. That's not saying that these are the only people that are business associates. It's just like,
I always say, look, if anybody else had control that you have on the network, would you call them a hacker?
Yeah, there you go. I mean, it's well known that typically your IT provider has the keys to the kingdom. They are the most powerful people in your organization.
And then you get the answer, well, we're not going to do anything with that data. We're going to protect it.
We're the good guys.
Yeah. That's why we have laws, because we can't trust you.
Yeah. And then another thing that we argued back and forth with a lot and still see it is the people that are doing, voicemail or, they have voice over IP systems or phones in place, and, somebody leaves a voicemail and the VoIP provider is like, well, we're not a BA. What do you mean you're not a BA?
Yeah, that one kills me. And there's this guidance piece that they point to that, it drives me insane. But I can tell you that the OCR is going to look at that and see that voicemail from a patient talking about their information. That little MP3 file is PHI.
Mm-hmm.
And so many of them, it's just impossible to deal with. But y'all need to get in line. Get in line.
Well, the funny thing is that some of the bigger companies that argued about it early on, they're now splatter HIPAA compliant VoIP all over their website.
HIPAA certified.
Yeah, so it's like, okay, were you not a BA, or you now realize that you are a BA? Are you saying you were wrong?
Yeah.
But at least they're paying attention.
Yeah, and the other thing is now I've identified a BA. What do they have to do? Is 45-minute annual training on a video really going to protect patient privacy?
Gosh, please.
If it's a data center, do they need to know? What do they need to know? I mean, I don't think all BAs are the same. But
yeah, that one's definitely kind of, scratch your head.
Yeah.
I understand it, but I don't necessarily agree with it. But not that I have to agree with it.
I know, right?
It doesn't change anything because I agree or disagree. But yeah, I mean, if you got a server sitting somewhere and, you're managing it and you're doing everything else, and somebody else is just providing the, layer of security on top of it and giving people a bigger pipeline to use.
Well, they're providing the physical safeguards and part of the technical safeguards. So they're providing, you are outsourcing some of the requirements to them. So I can see it's very similar to the IT company, Technically, they could pop something in there and monitor that traffic and you couldn't do anything about it.
This is true.
But what does, when I look at that, they don't actually have the ability to log into the servers, but they have control of the firewall. They have control of all the traffic. And, those aren't, if there's a VPN involved, they're controlling the VPN. So they could actually be watching all that traffic.
Yeah.
So that part, you need to be a BA and be responsible for that.
And then that, one thing that brings up is the whole cloud servers thing, which is, a lot of people are going to. Mm-hmm. You have a server that's in Amazon or a server that's in Google or something like that, and you still have the same issues.
Yes. So those BAs, I think there needs to be a lot. Then we also need a real world case study about a ransomware attack. Please.
Yeah, this is true.
Nuke and pave, boys. Nuke and pave. But, we need something that makes it clear, because you get either, you get one side or the other. And, we're working really hard to educate people that says what the guidance says is it must be treated like any other exposure. It doesn't say once you've had a ransomware attack, you need to notify your entire, everybody that was involved. It doesn't say that.
It's a breach by default.
Yeah. It doesn't say it requires notification. It says that it's a breach. All breaches don't require notification.
Mm-hmm.
And that's the difference. It can be a breach, meaning the access occurred, but can we prove that it's a low probability of compromise, or it meets one of the exceptions, which if you do it right, you would meet exception number 3. But but you've got to be able to prove it, which is, you don't just start notifying, which is what some people do. And then on the flip side of that, you don't just nuke and pave and say, well, I saw what it was, so I don't have to worry about it.
You selectively nuke and pave.
I know, right? I know of cases where they get hit with a ransomware attack and, they set the servers aside. They do nothing with them. And they just spin up another one because they're doing the cloud virtual server thing. And they just start working again. Nobody does anything to figure out what happened. Oh, well, we didn't, it was just ransomware. No big deal. No big deal.
Yeah.
And then they get hit again. And it's like, wait a minute, what's going on here? Well, when you do the forensics, then Peachtree Neurological found that there had been somebody in their network messing around, for months before then. And they found it because of the ransomware attack.
Mm-hmm.
So the ransomware attack didn't require the reporting. The hacker that had been in their network required reporting.
Yeah. Yet another case of where a hacker was exposed because they should have patched all the systems for the victim. So they wouldn't have been exposed.
That's right. But that if we had that where it really said, this is a case of what happened and this is how it went right.
Mm-hmm.
And they didn't notify, but anyway, that would be great. I would love to see that so that it clarifies some stuff. I would love to see a change on the encryption thing that says if it moves, encrypt it instead of just addressable.
Yeah, it'd be nice to have a requirement around that, I think.
And if I have a server sitting in a huge data center in a cage in the middle of 15 layers of security, do I have to encrypt that one? Maybe not. Maybe not. Maybe I wait until I'm upgrading the server and then encrypt the drives. If it's sitting there and it's been there for a while and we only use it for X, Y, and Z, and I need to shut everything down and encrypt and all that, I should be able to say, all right, that's reasonable. I've got 14 other layers of protection. And if somebody hacks it, encryption doesn't help you, which is another thing that needs to be clarified.
Yeah. So the chances of somebody stealing it are slimmer.
Yeah. But if it moves, it should be encrypted, period. And I don't
Mobile
care.
Mobile devices, laptops.
I know. I love the ones. We have laptops, but they never leave the office.
Yeah, whatever. They will when somebody breaks in.
I know. Do you know how easy it is to walk out one of those? We have a case where somebody walked out of an ICU with one. Now, come on. Yeah. If they could do that in an ICU, they can do it for you. But, we could definitely come on with a long list of stuff that, that would make things change. But I think one of the biggest things that they could do, and we talk about this a lot, is what do you do to get people to wake up and take action?
That's a whole episode.
I know. And we've talked about it over and over and over that, people just don't care. And then they'll say, well, they can't sue me. If I screw up, they can't sue me because HIPAA doesn't let them sue me. Or, even if they do, it's just some legal fees for the big entities. They don't care. And so for them, OCR is not dishing these things out left and right. And the only thing that really is happening is people trying to sue them. And there are two areas that allow them to hide from those lawsuits. And there are plenty of attorneys out there trying to figure out, and it's starting to go through state courts and state Supreme Courts and changing the landscape. But there's two areas that they are able to hide behind. And I'm not for suing people left and right. I don't like that. But some of these people, that's all that makes, if I can take your money, that's the only thing that'll make you pay attention.
Mm-hmm.
So the two things that the big entities, particularly the big ones, is, those are the ones that have the most infractions anyway, is they hide these privacy and security cases under peer review exemptions, which means I can say this is under peer review, and the courts have already said peer review means I don't have to tell you what happened. And that allows people to, if a doctor makes a mistake, they're only human a lot of times. And the peer review process is to evaluate, was it just an honest mistake? And they need to be honest and talk about it amongst the physicians. And if there's something they found that no one knew they needed to do or special case, I want them to be able to talk about that in private and not worry about somebody suing them over that conversation.
Mm-hmm.
But when you include that somebody told somebody's ex-boyfriend's girlfriend's baby, blah, 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 about something, and repeated violations of the privacy rule, and basically saying you can't do anything because that's peer review, and we don't have to tell you what we found and what we know they did because it's under peer review, I think that's completely different. And there needs to be some transparency there. And then the other area is you can't sue me because there's no harm. And I can tell you, like I said before, there's plenty of people that say, I don't feel comfortable sharing private information with my doctors. I can't trust them, which impacts my ability to receive proper care. So therefore, I've definitely experienced harm.
Yeah. If you don't trust your provider, find another one, but sometimes you don't have that option.
Yeah. You're going 50 miles away. What if you can't drive that far?
Yeah.
And there's plenty of those things. And it's more expensive when you go to those because everything's based by the region you're in. So there's a lot of reasons that's not good, but I don't like the idea of having to do that, but I can tell you right now, that may be what it takes.
Well, I think kind of the bottom line is that if you want change to happen, it's going to have to come from pressure from patients. Mm-hmm. So whether that's through lawsuits or finding another provider or whatever, it's got to come from the outside. And
it's unfortunate, but it's true.
Yep.
So That's all I have to say about that.
So there are changes a coming.
We just don't know when.
We just know when or what. But we do know one change that won't happen. It ain't going away.
Yes. Quit worrying about just compliance, because we know compliance isn't security and security isn't compliant. You got to have both.
Yeah. Yeah. I love, we were talking about the MPPs earlier. It's, people have them posted on the front desk or whatever. And then when you start asking them about, okay, this thing says you're doing this to protect this. And they're like, no, we're not doing that.
I know. I love to ask people, have you ever read it? No one has ever read it in the whole office.
Yeah.
I was like, you should read it, because that's what your contract says you're doing.
Yeah. Well, I mean, even just last week, I had a conversation with a prospect. It was a small chiro clinic. And, one of the things out of his mouth was, I don't understand why people would want my patient's data. It's not that valuable. And I'm like, why are we still talking about this? I don't understand why people still have that viewpoint.
I got nothing.
So anyway, I tried not to put my soapbox down in front of him. I was like, we'll talk about this more later. In the meantime, go listen to Help Me With HIPAA.
No, I just want to keep a certain list of episode numbers nearby so that I can always pull out a card and say, here, this number.
That's what we need. We have to have business cards with different episodes or certain episodes already on the card. Just hand that out. All right. Well, that brings us to the end of our first show of 2019. So we want to thank you all for listening. Remember, follow us and share us out on your favorite social media site. Rate us on the podcasting app. We need your help. Spread the word. And as always, you can send your questions or show ideas, and, kind of like HHS, we'll take a listen to it. So remember, for Donna and myself, that HIPAA is not about compliance. It's about patient care.
You've been listening to the Help Me With HIPAA podcast, hosted by Donna Grindle and David Sims. The show created to help you with HIPAA. For more information or to ask us a question, visit our website at helpmewithhipaa.com. Neither Donna Grindle or David Sims are attorneys, and they do not offer binding legal advice concerning regulatory compliance. The information in this podcast should not be relied upon or construed as legal advice in any way. Consult your attorney for legal advice concerning compliance with HIPAA regulations.